Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is the cutting edge of glaucoma, innovations and technologies in 2025 with Dr. Jeff Banas. He's a graduate of the Illinois College of Optometry and a member of the American Optometric Association, the Wisconsin Optometric Association, the Milwaukee Optometric Society, and is NBAO certified. He provides comprehensive ocular care for all ages, but specializes in ocular disease with a particular emphasis on treating glaucoma, dry eye, age-related macular degeneration, diabetes, cataracts, and refractive care. He handles pre- and post-operative care, and he's a member of an ophthalmology team that is on the forefront of adopting new technologies and techniques, providing the best level of eye care to their patients. So with that, Jeff, please. We're looking forward to hearing what you have to say tonight. I'm particularly interested in your topic, so please, Jeff, thank you for being here. Thank you for doing this, and take it away. You're going to be getting a warm OEC virtual welcome. Jeff, take it away, please.
Well, thank you everybody for joining me this evening. As Dr. Swoko was so kind to introduce me, I am Dr. Jeff Banas. I am the lead optometrist at the eye centers of Racine and Kenosha in southeastern Wisconsin. I do a lot of primary care in general, but my focus, as we had mentioned here, is glaucoma and cataract refractive surgery in particular. So this is a topic that is near and dear to my heart, something that I am very passionate about. Hopefully that is conveyed this evening to all of you as I speak about a number of the new innovations and technology that is available to us and to our patients out there now and moving into 2026 as we come to the end of 2025 here. Financial disclosures, we'll be talking about a number of things that are relevant to some of these companies here this evening. And the topics for discussion, the things that, I'm really going to try to talk about. I've got a lot crammed into this lecture. I could probably go on and on for hours beyond the 2-hour time limit that I have. But we're going to talk about understanding the burden and challenge of glaucoma. We're going to talk about some of the advances in diagnostic that includes imaging, AI, continuous IOP monitoring. We're going to talk about something that, I'm very excited about, the laser innovations that are out there, not so much SLT in itself as that has been out for a while, but the DSLT and the flight procedure via the via lace, something that I'm very excited about and that we are going to start doing in our office as early as next week, actually. We'll talk about some of the newer microinvasive and non-surgical interventions that are available to our patients. We'll talk about sustained drug delivery, smart devices, all those things that really get into the nitty-gritty. We'll talk about personalized care and future trends. And if we have a chance, probably won't tonight, but if I do get a chance, we'll talk about real-world case studies in our interactive discussion. So why are we talking glaucoma? Why is glaucoma on almost every, requirement for relicensure and CE requirements here? Well, there's a large global prevalence of this. About 80 million people worldwide have glaucoma as of 2020. The global prevalence is around 2.2% in the general population over 40 years old. And in the US, that represents about 2.56, 2.5% of people age 40 or older have glaucoma. And obviously, this prevalence is going to rise with advancing age. More specifically, that equates to about 4.22 million Americans had glaucoma as of 2022, with about 1.5 million having vision affecting glaucoma. So that's about 0.5% of adults. The prevalence in the United States is going to vary by state, with Mississippi having the highest rate, about 1.92%, and Utah having the lowest, 1.1%, females having a slightly higher prevalence than males. In terms of future projections, where are we going with this? The number of people affected by glaucoma worldwide is expected to increase from that 80 million in 2020 to approximately 112 million by 2040 due to the aging populations and other factors. So this isn't going away. It's growing. It's something that we have to take seriously in terms of the disease burden. Glaucoma is the second leading cause of blindness globally after cataracts, responsible for about 9 to 12% of blindness in cases worldwide. So it's why, my focus in practice is primarily on cataract refractive surgery and glaucoma. These are the two biggest things that are affecting our patients, something that, I want to be on the front line of in terms of taking care of. So, just a quick overview, glaucoma pathophysiology. Glaucoma is a group of progressive optic neuropathies. It's characterized by a degeneration of the retinal ganglion cells and their axons, which is going to lead to that optic nerve damage and loss. IOP currently is really the only true modifiable risk factor that we have. The key elements there, IOP is determined by the balance of the production of the aqueous humor by the ciliary body and its drainage through the trabecular meshwork uveoscleral pathways, and that elevated IOP usually results from increased resistance to the aqueous outflow. Not necessarily over-secretion, but that does happen at times. Um, IOP is really determined by the balance between the production of that aqueous humor from the ciliary body, that's represented by, number one here, and its drainage through the trabecular meshwork and uveoscleral outflow pathways, that's indicated by number two and number three here. That elevated IOP usually results from increased resistance at the level of the TM. So, open angle glaucoma, that drainage angle appears open, but there's resistance there at the trabecular meshwork. We can have other forms of glaucoma, in this case, I listed ankle closure glaucoma. That's where the iris physically blocks the drainage angle and acutely or chronically obstructing outflow. That isn't necessarily, the most common. In terms of that optic nerve damage, how exactly does that happen from that elevated IOP? Well, that causes mechanical stress and strain on the posterior structures of the eye, particularly at the level of the lamina cribrosa where the retinal ganglion cells exit the eye. That mechanical compression from high IOP then deforms and compresses the lamina cribrosa, pinching those optic nerves and blood vessels, leading to that axonal damage. And that disrupted axonal transport, kind of compression in itself blocks that axoplasmic flow. That deprives the retinal ganglion cells of neurotrophic factors from the brain, which then is going to trigger that cell apoptosis and death. And we can also have vascular insufficiency as well. Elevated IOP can reduce blood flow to the optic nerve, contributing to ischemic injury and further ganglion cell loss as well. So that really brings us to, what are the traditional management challenges that we face with glaucoma nowadays? And number one is really early detection and diagnosis. Glaucoma is asymptomatic in its early stages, right? I think we all know that. That makes timely diagnosis difficult. Excuse me. And that detection really relies on regular assessment of the optic nerve structure, so our imaging and then function, our perimetry. But unfortunately, these are not always accessible or even more unfortunately, routinely performed, especially in resource-limited settings. And then say we've detected glaucoma, then what do we do in terms of the choice and complexity of treatment? We're blessed with a plethora of riches. Where do we start? What do we do? Where do we go with what options that we have in selecting that most suitable therapy, whether that's medical, such as topical drops, laser, or surgical, really requires careful consideration of the disease state, the patient's comorbidities, risk factors, and each treatment modality has its limitations. There is no perfect, option here. I'm going to talk a lot about the surgical things that are available to us now and that are coming along, in terms of the pipeline, because I think that's something that not everybody gets exposed to as frequently, but medications are something that we have new technologies into, but those require lifelong use. They can cause side effects and they can be expensive. Laser therapy has its shortcomings as well. It's not always effective long term, may need to be repeated. And then surgeries in themselves, trabeculotomies, tube shunts, they're effective for lowering IOP, but they're associated with complications, hypotony, infection, high reoperation rates. They're not perfect either. So, these are things that we have to face in our everyday management of glaucoma, something that we have to take into consideration. And this is really a wonderful slide. I think, for me, the most important slide of the lecture here, if you take anything out of it, focus on this. This is a slide that was provided courtesy of Dr. Robert Weinreb. And this is called the glaucoma continuum. And when we look at this really kind of shows us, the spectrum of glaucoma and that disease state. We've got that undetectable disease, but you can see all these things that are really happening on that end of that spectrum. You still have that acceleration of apoptosis. You've got that ganglion cell, death and axonal loss, retinal nerve fiber layer changes that are occurring, but they aren't detectable. And that continues to go on through the asymptomatic stage. And then eventually we get into, functional impairment here, where we're starting to see perimetry changes. We're starting to see varying degrees, whether that be early, nasal step out to moderate, severe, and then eventually blindness. So our challenges that we're faced with now, and what a lot of this newer technology, especially from a diagnostic standpoint, is trying to move that needle from operating in this already functional impairment range when we're now picking up glaucoma into being able to pick it up earlier in some of this more, asymptomatic disease, move it from the red area into at least the green or yellow area, if not the blue. And that'll be a number of things that we'll be talking about tonight. Let's talk about traditional therapy. Let's talk about what I like to refer to as the legacy paradigm, our eye drops, something that, medical management means for most of us optometrists, unless we have the scope of practice that allows us to do things like lasers or some of these other procedures. Most of us are operating in the medical management area. And I'm not saying by any means, as I go through, some of these surgical interventions that are or options that are out there for us in glaucoma intervention and management, that eye drops don't have their place, or that we shouldn't use eye drops, or that eye drops are bad. But the reality is compliance to eye drops sucks. It really is the fact of it. Spin the wheel here with all the limitations that we have for it, whether that be for forgetfulness, the cost of medications, complexity of dosing schedules, physical difficulties, whether that be arthritis, poor hand-eye coordination, side effects, all these things take into account why a patient might not be compliant with topical drop therapy. And we've all seen this too often, whether patients are having difficulty administering the drops, or it takes a whole army to help them get the drops in the eye. These are some of the challenges that patients have. But, working in a cataract refractive surgery practice, I pay attention a lot to dry eye and the impact that dry eye has in terms of just prepping our patients for surgery. And there are studies out there that show the incidence, regardless of the number of drops that the patient is on from a glaucoma standpoint, whether they're on one drop, two drops, three drops, the incidence of dry eye amongst these patients is, the fact is, there's the majority of them have dry eye, 50 to 60% in this study's case. So you can almost count on it, that the fact is, if you're going to put a patient on on medication, they're likely going to develop some form of dry eye over time. When we look at, decrease in contrast sensitivity by glaucoma stage here on the left, we can see that decrease over time in cycles per degree with the advancing stage. But look at the right here. It's a very similar graph in terms of the presentation of patients' contrast sensitivity with dryness as well. So, you've got that normal graph in the green, but you've got dry eye, without central SPK in the middle, and dry eye with central SPK in the blue line on the bottom there. It looks very similar to glaucoma. So combine those two, we're putting patients on topical medications. They're developing dryness. This is also impacting the quality of the vision and their quality of life ultimately. And, some of the things we might not think about is, maybe if they don't have central SPK, their vision might still be good, and that it's not really impacting their quality of vision. They might be measuring, 20/20, 20/40, somewhere in that range on the chart. But this study still shows that there is a loss of contrast sensitivity in that quality of vision. So something to keep in mind, when we're putting patients on drops, it is impacting that quality of vision. I think we've all seen this, some version of this slide over time, just the preservative load and how the preservative can affect the ocular surface, lead to inflammation, cause damage in the tear film. These topical these preservatives in topical eye drops have been shown to increase the frequency of discomfort, stinging, burning sensations compared to preservative-free drops. We also have to take into consideration the residence time of these medications. There's precorneal elimination. The body is going to try to flush that out, or the medication, depending on its vehicle of delivery, is just not penetrating through that tissue maybe as effectively as we would like. And really, in case of this study, less than 5% of the applied dose reaches the ocular surface or the intraocular tissue through the ocular surface. So another, limitation that we have for topical drops. MGD in itself is more specific to PGAs than to other types of medications. And ocular surface disease has been shown to be associated with, infection after glaucoma surgeries. I'm going to show you a video later in the lecture of why we try to get patients off of, some of these drops, at least for a period of time, preoperatively, to reduce inflammation and help improve the patient's likelihood of good outcomes. And failure of blood-based glaucoma procedures has been associated with exposure to glaucoma drops containing that preservative BAK. It increases inflammation, which then increases the likelihood of scarring and that bleb failure. So that's something that we have to take into consideration. This is a great video that I encourage people to use, their Ratten filter, because you might tell me, yeah, I have patients on topical drops and I don't see any staining. There isn't as much dryness as you might, or you're suggesting that I am in this lecture. But look at this video right here. You see the difference there? with the Ratten filter and how much more can stand out. It's really easy to get a Ratten filter. If you don't have one, I would encourage you to utilize it more frequently. Almost all of my dry eye assessments now come with a Ratten filter here because you can just see so much more detail stand out, and you'll see so much more SPK that you might be missing at the end of the day there. So don't just use your fluoresce and your typical cobalt filter. Get one on Amazon if you don't have it. It's pretty cheap, less than $10, and you'll be able to see a lot more prevalence. Could help you diagnose some of the difficulties that patients might be reporting to you that you might be having a difficulty seeing. And this is
Hey,
a
Jeff,
clip.
real quick here, just real
Yeah.
quick, just so the audience knows, you can they're sometimes installed on the microscope, and you can flip a switch, or if you buy one, you put it on the between the patient's eyes, and I don't know whatever the oculars are on this side and the lens is on this side. You can put that
Yeah.
Ratten filter in there. I would encourage people to get one. It's not hard to use. You just have to hold it up in front if you buy the $10 version one.
Yeah, thanks for that, Greg. I didn't mention that. Fortunately, my slit lamps have it built in, so that's also another, easy way for me to say to use it all the time. But if you don't have one, that's why I was saying you can get it pretty readily on the internet, Amazon. This is a quick little clip from a favorite show of mine back in the day, just kind of showing
It's
a
the basic
process.
truth of the human condition that everybody lies. The only variable is about what.
So my moral of the story behind that is I don't care what your patients are telling you, how compliant they say they are. Nobody's 100% compliant. There are things that come up that we had listed, numerous times here already. Nobody's using those drops 100% of the time. And when dry eye is involved with this, in the case of this study, patients without dry eye symptoms, they weren't 100% compliant. 89% of the patients reported compliance with the medications, and patients with dry eye symptoms, went down as far as 63%. So, when you're seeing fluctuations in your pressure readings and or the pressure supposedly is staying well controlled. Think of it like the dentist, where you're going to brush your teeth right before you go to the dentist. Patients will often use their drops before they come in for a visit with you, but in between those visits, especially if there's months in between those visits, they are likely not utilizing those drops consistently. That'll cause fluctuations in the pressure, which in my opinion are just as detrimental as high eye pressure in itself, and that can cause damage to the nerve and your visual field. And that might be a reason why you're seeing progression in your fields and your RNFL scans, despite consistent readings for those patients being in the target range potentially, because they're likely not 100% compliant regardless of the regimen that you put them on. So we have to ask ourselves, at least in terms of if I ask myself, what do I do? The goal of glaucoma treatment is to minimize the lifetime risk of visual impairment, balanced with the need to minimize harm from treatment. Then we can't ignore these issues. We have to pay attention to the issues that the side effects of these medications cause. Lash growth might not be a bad thing for the entire demographic that we put those patients on, but some people are bothered by that. The hyperemia that can occur, the pigmentation change there in the colors of the iris, depending on the medication that you're using, periorbital changes, whether that be fat loss, lid changes that can occur. You can get ptosis from some of these medications. All these things are impacting that patient's quality of life, and we have to take that into consideration. So to me, the art of glaucoma management really has to be redefined a little bit. It's not just about managing, the objective measurements here, the eye pressure, the visual field, the optic nerve heads. It's also about combining that with quality of life. We have to take into factor both of those, because if you look at this patient that I have here on the right, we'll say her pressures are controlled. We'll say her optic nerves and visual fields look great for, what I'm trying to achieve. But I would argue this patient is not well controlled. She's not happy. She's got, cosmetic issues here that are likely impacting her quality of life, her compliance with our therapies, and she is probably worsening to a degree at a certain rate than we may maybe not be able to detect, but we don't know, how consistent she is being with those medications. So we have to find a way to balance all of this, and that's why, innovation in glaucoma matters. These traditional approaches, such as eye drops and invasive surgeries, like I said earlier, they have significant limitations, including poor patient adherence, side effects, and risks associated with surgical complications. Just like you and I, glaucoma is only young once, so we have to do something, in my opinion, sooner rather than later. That brings us into our first innovation, our first area of talk tonight, and that'll be about glaucoma lasers. Now, As I mentioned earlier, SLT as a first-line treatment, this is not something that's new. SLT is not recently on the block. It's been around for a while. The light trial is well established. We're all probably pretty well familiar with this, and the light trial really showed us, less chance of progressing over 6 years. There's less need for incisional surgery or cataract surgery, and there's a cost of savings to the healthcare system by reducing the dependence on drops. Patients don't have to fill the drops. But there's a number of societies here that I listed that have differing opinions on where SLT fits. And some say SLT should be offered as a first-line therapy for treatment for opening glaucoma, ocular hypertension. Others say it can be offered as a first-line choice, maybe used in initial or adjunctive therapy in patients with POAG. So even in some of these more, respected associations, there's not a clear definition of where and when we should use SLT. But we know, SLT really provides us good results. We've got patients up to, in this case, 69.8% of patients that had SLT as a first-line therapy. They were drop free, for a period of time here, and that's not necessarily all of them just had one SLT. 56% required one, 34 required, two treatments, 10% required three. But you can see how many patients were drop free, on the left there when they started with drops first as opposed to SLT. So even considering something like SLT to reduce that drop burden is something that I would encourage people to consider, because it shows, efficacy. But why else is, SLT not considered first-line therapy? Even when we Google it, AI nowadays involved in everything shows us that the widespread of SLT is not, it's still ongoing. It's not 100% taken. I think there's a number of factors that even Google listed here. For me, it's not just about the growing trend of SLT being incorporated earlier and that the data like the light trial is supporting that. But ease of use is something, it takes skill, especially for those of us that are able to perform this procedure. We can attest to this. This isn't necessarily as easy as we like to make it seem. It's not as hard as a more invasive procedure, but you need to place a gonio prism on a patient's eye, and that can be, somewhat challenging depending on how cooperative the patient is. You need to get a good view of the angle. You need to line up the laser, and you need to be able to deliver the treatment effectively. So, that can even make ophthalmologists that have the ability to perform this across this country is somewhat hesitant. Patients might prefer medication still as opposed to something like an SLT or a minor surgical procedure. So for me, that's really, one of the first barriers of there to SLT, like we talked about standard of care, but the patient discussion there, it's how you deliver this to the patient as well. And then we also have concerns for efficacy because it's not a forever treatment. It's not something that's going to, cure there is no cure for glaucoma. We know that, but SLT isn't a one and done, and then you never have to do anything else in the future. So that gives patients and other practitioners pause as well. And here again is another example. What do you do when you have a poor view of the angle like this? Ocular surface here can limit, your view too. When you've got the gonio. And then this is Dr. Inderpal Singh. For those of you that I haven't disclosed this to, Dr. Singh and I work very closely. I affectionately call him Sensei. He is the owner of the practice that I work at. So he is my mentor, my teacher, somebody that I've been able to get a lot of firsthand experience. You're going to see a lot of his surgical videos here tonight. But Dr. Singh had neck surgery, so ergonomics is a problem for him. He sometimes even has to get on his knees just to get comfortable to do a procedure like this. So it isn't necessarily something that is just clean and cut. And, these images are designed to show that sometimes it can be a struggle. There's multiple lenses that can be utilized to get a good view. It's not something that is, always just straightforward. So for me, my challenge and how we deliver this to the patients really is ultimately how you discuss SLT with your patients. And you can get them to adopt it a little bit better when you use terms like rejuvenation. It's done in office. It gently enhances your drain. It's covered by insurance. Keep in mind, SLT is not altering tissue. We're not destroying tissue. We're not removing tissue. We are exciting the cells essentially to, ultimately start a pathway that will increase the outflow there. So that's where that term rejuvenation kind of comes. It helps the outflow function a little bit better. We don't have to go to a hospital. In our case, fortunately, we have this right down the hall in our clinic, so it's done right here. There's no pain or discomfort with this. this. And again, nobody likes to pay. So if the insurance covers it, that's a great, I don't want to say selling, but an option for the patient to, consider, as opposed to paying money for eye drops. And it's just like getting that OCT image, I like to say. It's just like a quick little picture. It's not anything that's going to, like I said, actually alter the tissue on the inside of the eye. This is a study that was recently published to kind of, interventional glaucoma is out there now, and something that a lot of these techniques are being utilized to treat in terms of moving the spectrum earlier and treat earlier with glaucoma. We didn't really have a consensus before. As I was saying, SLT is still not widely adopted as a first-line therapy, but now we have a study. This was published earlier this year. I'd encourage you to look this up and read it. This kind of gives some guidelines about, how we approach glaucoma and first-line treatment options, and, really where we're at nowadays in terms of the legacy paradigm versus the interventional glaucoma paradigm. Here's our first, really new technology that's out there now, DSLT. DSLT is SLT, but think of it more automated now. This is an automated treatment, so this makes it accessible to non-experts, people that might not be comfortable with performing that procedure. This takes a lot of the technical skill away. And now more eye care providers can offer something like this. It's got an ocular-free interface, so you don't have to put a gonio prism on the patient's eye. It's user-friendly. The patient can sit, the patient can stand, and in terms of the user utilizing something like this, I'll show a video of how this looks and how it goes down. But you essentially press a button, and the device will track the trabecular meshwork via an OCT through the sclera, and this thing fires the laser through the sclera translimbally. Excuse me. As opposed to trying to get a good view of the angle, with the lens and then firing that laser through the lens. So this is kind of an example here. The DSLT ultimately, there's a lot going on this slide, but here on the right, you can see that green representing the laser. Your traditional SLT is going to come from that gonio prism, directed towards the TM. This one translimbally through there directly there. So there's a little bit more energy that's output initially, but the amount of energy that's delivered to the TM actually reaching the tissue there is about the same. So pretty novel in concept. This is essentially what it looks like. The patient sits in the instrument. This is the interface. The user will press a button, and it's about as quick as that. It takes a few seconds. You can see that laser icon up in the top left kind of flashing. That's the amount of time of the treatment. Tells you exactly where it was treated. Patient's happy. Patient goes home. So now, this type of technology is going to allow us to utilize SLT for those of us that incorporate it into our practice as a first-line therapy a lot more easily and a lot more efficiently. We were actually the first clinic in the United States to obtain this device. This is pictures of some of the first patients that were being utilized. Here's a quick little video of what that day looked like for us.
Awesome. Don't move. Perfect. Here we go. And here's some beeping sounds. That's normal. Here we go. 1, 2, 3, and we are done. Beautiful job.
Okay,
That's a lot different than last time.
Yeah. I'm glad we moved it up. That was good. Yeah.
Look out for you. Here was a good time to come.
That was a good time. Yeah. So it worked.
Yeah.
That was cool.
Yeah.
That was a good one too to show.
Yeah, awesome.
Awesome. Let's take this out.
Take that drink afterwards.
Just take it a couple times a day. That's
I
really
know.
fun.
When do I have to
You
start?
could take it when you get home this afternoon and one time before you sleep. How's that?
Okay, good.
There you go. That was it. Isn't that easy?
That's a lot better. I'll give you a
A
hug.
lot better. Oh, I get a hug.
Yeah.
Thank you so much.
Okay.
So what do you think? You've had the lasers before.
That's a lot better than those rat-a-tat-tat things.
Yeah, the other lasers were a little bit more difficult. Yeah. And so, did overall any pain when the laser was going beep? Nothing at all. Not bad. And no jelly.
Surprising.
Yeah, surprising.
other than that,
And do you like not having a jelly in the eye
Yeah,
that we
and
had?
all that ring we got up there.
Yeah. So I'm so happy for you. Congratulations. You're more than welcome. See you
hope it
soon.
works.
Yeah, I do too. Let's have you wait for about 15 minutes or so. Then we'll check those pressures for you. Okay? That is awesome. See, you did great, Tommy. Congrats. Bye.
So the moral story that I want to make behind that, you might have heard the patient say a couple times it's a lot better than the previous one. So what we did with her was we did traditional SLT on her first eye, and then we turned around and we did DSLT on the other eye to compare it. And you can see firsthand testimony of one of our first patients already telling us, how much different it was, how much more comfortable it was. So definitely something to be excited about in the SLT space in terms of access to care, and access for our providers that, are going to incorporate this into practice. Here's another video of what it looks like on our end and how quickly and easy it is to, employ this once the
You're gonna hear
patient
some beeping sounds and then a green light and a clicking sound. Just don't move when you see that green light, okay? I'll count you down. Ready? Here we go. Now, don't move, don't move, don't move, don't move, don't move, don't move, don't move. And we're done. That's it.
Wow.
That was it. Not bad.
So that's it, pretty quick, pretty efficient, and you can, get the patient in and out pretty comfortably, pretty happily there. Here's the data from the Glorious trial, which was, the IOP observed over 12 months for a 6-month period of time as well. Pretty comparative results when we look at, DSLT versus SLT there over time. So, I will say anecdotally, I feel like just due to the amount of energy that's being delivered from the DSLT initially, I'm not seeing the initial drop as much as I did with SLT, but over time, I'm seeing it level off pretty similarly in that 2 to 3 month mark. So, as we've done hundreds of patients with this now, I would say that it is comparable, but it might take a little bit longer to actually reach the same endpoint there for some of our patients. But patients that are medication free, in this study, after 12 months, pretty comparable to the SLT as well, and how many meds that they were at the initial screening, and then how many patients are off there. We've got a significant number with, one patient on one med now being off, almost 50% there, 2 meds being off, and, 50% or 40% with 3 meds at screening. So at the very least, we are reducing the number of drops that the patient is on when you consider something like an SLT. So this is why I go to say that, it's not that drops don't have their place or that you can't still utilize drops, but if you want to reduce a patient's drop burden, especially in that, 2 to 3 medication range, this is a great thing to consider too, to try to improve their quality of life while still having, efficacious results here. More data here just showing how many patients have been reduced in terms of how many drops that they have post this type of procedure. Here, this is more, I'm not going to go through this in detail here. This is more for your reference. It'll be included in the slide deck that's uploaded there for you. But comparison, I always love comparison tables, just, SLT versus DSLT. So, procedure time, patient experience, operator skill, technology, eye tracking, side effects, most of which showing favorability profiles to the DSLT as opposed to the SLT now. So something to be really excited about. Here we are at our first poll question, Greg. So go ahead, fire it away and let me know when we can continue.
All right, the polling question's up. If you want to take up, you changed the order. Hold on. Let me close it. I thought that was it. That's not it.
And while Greg's doing that, we had a little hiccup with our chat box. So if you don't see the chat in the upper right hand corner, just refresh your page. It should show up.
If you want to take care of the polling question, Jeff, go ahead and read it.
Okay, so which of the following accurately describes the mechanism of direct SLT? Contact-based ablation of the trabecular meshwork tissue, that's choice A. Choice B, non-contact automated laser targeting of the trabecular meshwork to increase outflow of facility. 3, thermocoagulation of the ciliary body processes to reduce aqueous production. And D, destruction of Schlemm's canal to enhance fluid egress.
Okay, polling question is open, and people are weighing in. And I'm assuming with a little bit of snafu, Joe, with the chat box, again, for those that are out there, you can refresh your browser and the chat box will reappear so that you can will appear so that you can put the questions. So Joe, I'm assuming that there's no questions in the chat box.
Everything's handled.
Okay. All right, so basically the poll has a nice trend set, so I'll display it. You have basically 93% going with B, and then 3% going with A, 4% going with C, and no one went with deconstruction of Schlemm's canal.
Well, glad we made that one clear. Yeah, the correct answer is B, non-contact automated laser targeting. All right, let's move on here. So, VLux laser system, femtosecond laser image guided high precision trabeculotomy. This is something that I'm very excited about. We like to refer to this as a true lunch laser because you essentially dock the patient into this like LASIK, and then they will fire this out. But essentially, what we're trying to do here, this is novel technology designed to address some of those key unmet needs, and we'll talk about what those unmet needs are here shortly. But we're trying to reduce IOP by increasing aqueous outflow utilizing a micron resolution OCT image-guided femtosecond laser to non-invasively create a customized drainage channel through the trabecular meshwork in the vicinity of the collector channels. So think of it as a laser goniotomy, essentially. This is non-invasive. So again, femtosecond laser guided by OCT imaging. It's applied non-invasively to create precise defined channels without damage to adjacent tissues. Look at, we like to call this, anatomy porn here, where just the detail that you can see of the angle there. We don't even get that with our traditional gonio unless you've got really high magnification, but that's what we can see. So just in terms of identifying disease state, docking a patient into this instrument will allow us to really see the anatomy well here. And that's also guided with the OCT images that we can see below that. The treatment's programmable to allow access to all four quadrants of the eye, not just the nasal angle. When you think of, the surgeon and just the ergonomics of what they're doing, they're typically sitting temporally to the patient. They're not going to work over with their instruments over the bridge of the nose. So a lot of times their treatments, such as their goniotomies and their canaloplasties, start in the nasal angle, and they can't really get to the temporal angle. So this device allows them to treat all four angles. So one, again, we've got that unparalleled, proprietary illumination and that HD imaging capabilities to really visualize the angle, and that gives you that, 12 micrometer gonio resolution. You can see, our current state from a surgery standpoint. They've got that surgical gonio prism. You can see the limitations of the view there versus, what the VLACE will allow them to have. Again, the treatment being confined to the nasal quadrant currently just due to ergonomics, whereas in this case, the treatment's going to allow access to all four quadrants of the eye. Current state will require a handheld gonio prism. This doesn't require a gonio prism. Pressing on the eye with a gonio prism can change and distort the view. Again, we've got that proprietary imaging that allows a surgeon clear and undistorted view of the angle. It can be hard to fixate and stabilize the eye for this. In terms of the VLACE, that instrument stabilizes the eye from the docking procedure. You have little control over, eye, head, and body movement with the traditional surgical methods, where they're going to have full control in keeping the patient positioned. Again, think of it as like they're being docked into a LASIK instrument. This is what it looks like from a surgery standpoint in terms of the interface. This is what the surgeon's going to look at. You can see the clock hours in terms of the turret there on the right, and then the view that they have real time. So we're targeting 9 o'clock. We've got laser guided. You'll see the OCT show up there to the right. Tells them right where they're at. Fires away. It's about a 30-second treatment. That's just cavitation bubbles. That's not inflammation or anything going on. That's pretty normal. Orange, that obviously the laser is emitting. And then that's it. We get a nice view. Post-operatively there, that's what you'll see. So nice, clean, clear cut, less risk for inflammation, less risk for fibrosis and scarring because of how easy that was. And that's day one, nice and easy to see for those of us that are looking at this post-operatively. And then you can see the OCT image up to the top there. You can see, this little triangle right in this area. That's where, the TM was removed pretty easily, and then outflow, through the outflow system. And then in terms of, how long does this stay open? The data has been studied on this for, up to 24 months, utilizing anterior segment OCTs here. So you can see we've got that 500 by 200 micrometer channel, and that's still pretty well open at 18 months, 12 months. There may be a touch of scarring, but I would still argue that this is pretty well open overall. So pretty exciting options that are available. Here's the first, in-human safety study that was published there. I believe that was in March of 2023. So for reference, if anybody wants to look that up, I've provided that for you to get into that. Let's talk about data. At the end of the day, it's great if it can be easily performed, but it's got to be efficacious. It's got to be able to provide the results. Well, we've got a sample size a little bit smaller here, but no washout. 18 patients, no serious adverse events were related to the flight procedure. We're seeing about a 35% decrease, in mean IOP reduction, and look at how that's sustained from 1 week all the way out to 24 months. 88% of patients, eyes achieve less than 18 millimeters of mercury, and 82% of patients, eyes achieve more than a 20% reduction. There 53% of patients achieved more than 25% reduction. So now think about the options that we have available to us in the laser space. Say you start with SLT and you get a good response the first time around, and then it starts to wear off over time. You repeat it, and then it's wearing off again. Maybe you repeat it a third time, or now your surgeon has another non-invasive option to move forward that can hold the patient out for at least a couple more years. There's a similar procedure that I'm talking about later in the study called ELT, which is invasive, but similar in concept in terms of causing, goniotomy channels there, and they're actually smaller than this, about, still 210 micrometers, but I don't believe as tall. And they have data that extends out to 8 years, which I'll show that as well. So, having something that could potentially reduce drop dependence, reduce drop burden, or even eliminate the need for drops initially for even a decade is going to impact patients' quality of life dramatically. Let's move on for lasers to, drug delivery devices that we have now. So we've got intracameral options. We've got sustained delivery devices from implants here. Again, a review of the options that we have. Conventional topical therapies are going to include our PGAs, our alpha agonists, our cholinergic agonists, beta blockers, CAIs. But again, those barriers, they're inefficient. They have poor delivery and uptake, and they can have poor patient adherence. So we have other things like ocular inserts, contact lenses, intraocular implants, microelectrical chemical systems or mechanical systems and microinjections. We've got liposomes, polymetric nanospheres, nanoparticles that are being utilized to deliver more targeted therapy, and punctal plugs to have sustained release over time. And some of the examples that I have listed on here, Banas, we'll talk about that shortly, being the only FDA-approved SR therapy for primary open-angle glaucoma. And the advantages of sustained delivery really includes, increased uptake and precise dosing, increased efficacy, ease of delivery there for us as providers doing it, and it mitigates the need for patient appliance and adherence with some of the topical therapies. Here's are some of the examples of therapies under investigation: the Banas ocular ring, the iDose, and that's now actually on the market there. The ENV 515, OTX-TP, the Evolute we'll talk about. We've got emerging technologies such as contact lens drug delivery systems, nanotechnology for some of those sustained release drug delivery, and polymeric hydrogels. So really the idea here is that the optimization of sustained release drug delivery can improve long-term treatment outcomes in patients with glaucoma by mitigating some of those compliance challenges that we have. So let's talk about some of those options that we have out there. So Banas SR, this is a sustained release biodegradable implant for the treatment of open-angle glaucoma or ocular hypertension, designed to lower IOP for at least 4 months. While freeing patients from daily eye drop regimens. So this is 10 micrograms of Banas impregnated into biodegradable polymers. It's similar to those biodegradable polymers utilized in sutures. It's supplied to the provider in a preloaded single-use applicator with a 28 gauge needle. That's what it looks like in the bottom right here image if you were to do gonio on an angle. The applicator is shown there in the middle as well. Here's a little video of how easy it is for our surgeons or those of us as providers that can do it to implant it in the eye. The patient is numbed. In our case, we actually do it on both eyes just to decrease the dry eye reflex so the patient doesn't blink even from the other eye. line the patient up, and I'll show you another video of what the anterior chamber actually looks like here. But I'm going to line up temporally so the patient doesn't really see it coming. Go right in, press the button to release, and right out. And that's all there is to it. Quick and easy. Patient's happy, painless, pretty quick and simple experience. Here's another video. You know what you're seeing there again on the side, real time. This is just kind of to discuss about technique in slow motion here. What can happen is if you don't press on that applicator button uniformly, you can get a little air bubble that shows up there, and it can make that the implants stick to the applicator, and then you can find yourself having to shake it off, and that can cause problems. It can land on the endothelium. So what Dr. Singh was trying to demonstrate there in that video is you press down about halfway till that implant comes out, slightly give it a moment, and then press again because you're letting that air bubble kind of release, and then that allows the implant to free float down to the bottom of the anterior chamber pretty easily there. But you can see when you're looking at it, pretty easy to visualize even without a gonio prism on the patient. So you'll be able to get a good view of it. In terms of the data, again, primary efficacy results for mean IOP reduction in this, we're seeing about a 5 to 8 millimeter of reduction from baseline. Mean diurnal IOP consistently maintained between 16 to 17. So we're getting the patients in the middle teens pretty easily with this. And during that primary efficacy period, IOP lowering was numerically greater with bimatoprost SR than timolol at all 6 time points. So that's pretty impressive to show data like that. So, before you consider going straight to a drop, consider something like this. If you have access to this or something that you can do yourself, this is a way to keep the pressure down, even lower there. Bimatoprost concentration is highest in the target tissue with minimal off-target detection compared to topical drops. So again, we've got that precorneal elimination with some of these topical drops. A lot of that medication is not only not getting to the target, but it's hitting other areas as well. You can see topical bimatoprost here on the left. The concentration in the aqueous humor is lower than in the bimatoprost implant. That would make sense, right? You've got that cornea and that precorneal elimination blocking that medication from penetrating through that tissue, as opposed to going right around the cornea and just releasing the implant in there. You should have a higher concentration, and then you can see, higher concentration of it in the ciliary, iris and ciliary body as opposed to topical administration. And then we look at the right, you can see, all the areas that we're seeing topical bimatoprost land, whether that be the bulbar conjunctiva, the lower and upper eyelid margin, periorbital fat, as opposed to something like bimatoprost, we're only really seeing it concentrated where it's supposed to be, and that's inside the eyes a little bit, making it into the bulbar conjunctiva there, but definitely not as widespread collateral damage, we'll say, as opposed to something like a topical drop. So if we want something that's more precise and reducing the need for compliance and dependence and improving quality of life, that's how something like a bimatoprost comes in. I love to use these photos of Dr. Singh coaching me up so that you can share my experience as well here. This is him telling me you only have to identify one barrier. You don't necessarily have to treat everything. We're offering a solution to our patients. We're not selling them on this. We're not telling them that they have to do this. This is just an option if they're having compliance issues or, something that's a solution for them should they not want to use drops as a first-line therapy. And it doesn't have to last forever. I think that's something that, all of us think about. If I do a surgical procedure, I don't want to have to do multiple procedures. I don't want to have to do it needs to be something that's kind of long-term study and long-term efficacy. But where I was saying, think of something like an SLT, and it's not going to last forever, but it is going to improve quality of life, and then it can be repeated, and then you can continue, and then potentially move on with something like a VLACE or add a sustained release delivery. They can be combined so that you can get a longer therapeutic effect over time. They don't necessarily have to be one and done and ultimately remove the need for drops altogether. Here's the data on bimatoprost here. We've got multiple studies, phase 1 and 2, the Apollo studies. About 36% probability of surviving 360 days without rescue treatment. That means, restarting drops, adding drops again. And 26% of probability surviving 720 days. So there is a period of time that patients, get benefits from this. Not everybody, obviously, but it is something to consider there. In the phase 3 study, 86% of patients here had a probability of surviving 360 days without rescue after a third treatment. So this is where they did bimatoprost, waited about 4 months, did another bimatoprost, waited another 4 months, did another round of bimatoprost. So that's why a lot of difference there between 36 and 26 versus 86% surviving 360 days, because they kept adding more bimatoprost there. The mean time to IOP being, 22 millimeters of mercury during washout of topical PJs prior to baseline was about 42 days there. Bimatoprost reduced IOP by approximately 30% over the 12-week primary efficacy period, meeting the predefined criteria for non-inferiority to the study comparator timolol. In terms of the observed baseline ME-IOP and observed mean change from baseline IOP in treated eyes, the bimatoprost intracameral cameral implant with standard of care, including ongoing IOP-lowering medications and the additional implant. You can see essentially moral of the story, mean target IOP here, 15 millimeters of mercury. So when I'm thinking of something like this, mean change of baseline, down 1.1 millimeters of mercury, down 2 at 6 months, down 1. What they're essentially showing there is you can have a patient on a drops, you take them off of drops, you put them on something like this, they're going to lower by, even 1 millimeter of mercury in comparison to the topical drop that you can have them on. So, not only reducing the concern for compliance, but lowering that pressure slightly further there. Same, kind of data presented a little bit different way here, where you have that baseline pressure hovering more around the upper middle teens there, kind of 18. And then after treatment of this, even at multiple time points, month 6, month 12, month 18, most of these patients are down to the middle teens there. So pretty efficacious with the overall concept. Here's the problem with bimatoprost. We've got endothelial cell loss essentially when they did multiple doses of the Durista implant, which is the brand name for this. So we did up to 3 administrations. They saw about a 5.4%, patients reporting endothelial cell loss of varying degrees. And that's why the FDA only approved it for 1 single administration. And not multiple doses of it. So that's the one downside to something like Durista, where you could get effects of it out to a year, but your primary efficacy has really been studied in those first 3-4 months, and you can't repeat it after that. So you have to start looking into other things. But we like to utilize something like Durista in the concept of where if you're preparing a patient for surgery, and you need to get them off of drops for a period of time to, again, improve the likelihood of better outcomes so that the patient isn't going to, if the patient's on a PGA, for example, before surgery, and you have to do something like a Zen procedure, that conjunctiva is probably going to be irritated, going to be inflamed. And if you go in and you do surgery on that and make it even worse, there's going to be an increased likelihood of that bleb scarring down and fibrosing. So if we can get them off of the topical drops for a period of time, this is one of the ways that we do that before we prep them for surgery. So that's where we like to use something like sustained release in our clinic. In terms of intracameral implants, another option here is iDose TR. This is a device that's anchored into, through the TM into the scleral wall. This is designed to provide continuous long duration drug therapy to address ubiquitous patient noncompliance with topical medication. So all the same things that I've been talking about here. This is a canister essentially with a membrane on the inside there for that elutes the travoprost long term. It's got a proprietary preservative-free travoprost formulation. That travoprost, again, is proven to be safe and effective in its natural state. It is a concentrated oil, and then highly concentrated in this concept, 25,000 times travoprost oil formulation. Very easy to insert here, just like, and I'll show you a video of this as well, excuse me. It's on a single use applicator that the surgeon just essentially presses through the TM and anchors into the scleral wall and releases it, so it doesn't take any crazy surgical technique to do. And it stays fixed and stable there for its entire time unless we remove it. Here's a quick video just kind of showing the trocar there. You can see in the bottom, Dr. Singh is holding the device. We'll turn
Get
the
ready
volume up
prism
here.
here. Going to go ahead and just get a good view, an en-face view of the nasal angle here. You can see nicely there. We're going to zoom in, and you can see I'm going to insert my loader here with the iDose. Going to go straight across, entering at the level of trabecular meshwork, going straight through into the scleral wall. Good constant pressure, holding it. Now releasing those prongs, coming straight back. Then I'm going to go ahead and close the prongs, tap it left, tap it right, again, tap it left again, and there we go. We've confirmed it's stable and anchored in the scleral wall. That's what I love about the iDose. You don't have to cannulate anything. You don't have to worry about it going into the canal, just through into the scleral wall. And now we're going to go ahead and release and remove some viscoelastic, and that's it. You can see how stable the iDose is in the nasal angle as well. So here's an example of iDose, or the example rather of interventional glaucoma rather, where I think iDose can help. I think there's a patient who was having an issue with topical medications on a PGA and a combination, but clearly was telling us that she was not able to take it every day. So hopefully this will give her the opportunity to not only get her off the PGA for a while, but even potentially, based upon compliance issues, maybe even get off of the combination therapy as well. Hope this video helped everybody.
So, the idea there is that it's really easy for the surgeon to implant and then, reduce drop dependence. Another question that we get is repositioning in case for any reason the device moves or, if there's another surgery. What Dr. Singh was trying to show at the end of that device was during irrigation removal, that AC, the fluid in the AC is just whipping around, and that should make things kind of move around pretty easily in there. But you could see, in that video how the iDose was pretty well anchored and didn't move. But if any reason he wanted to remove it, this video will kind of show how easy it is for
pretty
him to
much
do that.
just above the level of TM. So it felt pretty good actually, and it felt pretty stable. But when I looked at it externally, you can see how there's a little bit of that scleral anchor showing way up top there. In fact, I'm going to show you here in a sec with a high mag view and a still view here, and watch this arrow. That's the scleral anchor exposed there. Now, that could be because I'm a little bit anterior in my positioning versus through the TM. I'm about Schwalbe's line area. That could be why we're seeing it, even though it was stable. I said, let me go back in and remove it. So I'm just gonna go ahead and engage, not at the cap, in the safety zone, pull it out, and I'm gonna go ahead and reposition it here, just a little bit to the left there, and I'm gonna go a little bit further down at the level of TM. I'm pushing a little bit harder too, just to be safe. That's why I lose my view there. But I'm push, and again, release those prongs, and then tap it side to side. And so now I'm a little bit more posterior to the Schwalbe's line or below it than I was before. You can see here now, you can see the heme reflux, that's going through the trabecular meshwork into the Schlemm's canal. So I think because of that, you're not gonna see the scleral anchor quite as much. So it's hard to say if I was just not in far enough before, or I was just more anterior, which is why you could see that scleral anchor. But just to be safe, I like to reposition it. And you can see here in high magnification, you don't see that scleral anchor anymore. And if I do a side to side here before and after I reposition, you can see the difference in how that scleral anchor looks. You can't see it on the right, which is, I think, the ideal positioning. And now I'm just going to remove the viscoelastic with some automated INA. You can see how stable that iDose is, doesn't shift or move at all. I'm using high vacuum and irrigation here just to confirm that it's not moving. And now I'm just going to hydrate the wounds, and that is it. Pretty stable surgery, pretty straightforward, but I hope.
So, moral of the story there is if you saw when he took it out, there wasn't a lot of scar tissue, there wasn't a lot of fibrosis. It was like if nothing was there, takes it out, reposition it very easily. It's very easy on the patient, minimally invasive. So, something that is very good to consider in terms of, like I said, reducing drop dependence, reducing drop burden, and easy from a technical standpoint for our surgeons to do, especially if, there's any complications with its positioning. Here's another video of just kind of he's doing phacoemulsification on the cataract, utilizing a lot of energy, and you can just see how the iDose is staying well in good position. It's not moving around, so we don't have to worry about this thing falling out after insertion. Over time, it stays pretty well in position. You can see right there, a piece of the cataract just went up and hit it, but he's utilizing a lot of energy, a lot of irrigation to get all these pieces of the cataract out of the eye, and that iDose is just staying well in good position. So let's look at the data. We're going to go, over this data in a little bit more depth here. So I'm going to skip over this slide real quick, but we've got phase 3 and phase 2B safety profiles here. Really a strong safety profile without compromise through 36 months. No clinically significant endothelial cell loss, which was what the big concern with the bimatoprost implant was. There's no periorbital fat atrophy. There's no serious corneal adverse events, no DSEC, no DMEC. These patients' endothelial cell density stayed pretty consistent over the course of the 3 years there. Intraocular pressure increased in terms of some of the more adverse reactions that we're seeing, mild to moderate, and they resolved over time. You had a little bit of iritis, a little bit of dry eye, 22.6% visual field defect, eye pain, 2.3%, 2.2% ocular hyperemia. And 98% of the patients remained in the clinical trial. So pretty strong safety profile. A lot of these, adverse events are consistent with what you would see in other surgeries as well. In terms of control of the pressure at 12 months, 81% of patients, of the iDose TR subjects were completely free of IOP lowering topical medications, despite 23% of subjects being on 2 or more medications. Think about that. So, for whatever reason, we put that iDose in the eye, and they were on 2 or 3 medications, and now they're controlled with just the iDose. That has a strong, correlation with patients that even though you put them on 3 medications and they weren't controlled, right, they probably just weren't taking all 3 of those medications. That's likely what was happening there in that sense, and why they're controlled with something as simple as an iDose, long term. Similar in terms of what I was trying to demonstrate with the bimatoprost here, the PGA responder analysis. When you look at the pre-trial PGAs, we'll say the patient has an entering IOP of 18 millimeters of mercury. We wash those patients out, meaning we stop the medication for a number of weeks. The pressure obviously is going to go up. We go back up to about 23.8 in this case. We give them an iDose, and they demonstrated a 1.3 millimeter of mercury statistically significant superior IOP lowering versus the pre-trial PGAs. So, they went down to 16.7 after the iDose there because, again, compliance, precorneal elimination, all that kind of stuff. So you're seeing even better IOP lowering from something that is delivering a more targeted treatment. In terms of the pharmacokinetic trials, which demonstrated the durable drug concentration there, we're looking at, the levels of travoprost free acid in the aqueous here. So mean TFA levels were above the Cmax concentration of TFA 1.78 nanograms per milliliter determined after the dosing of topical travoprost. And levels were also above the efficacious TFA level 0.095 nanograms per milliliter, estimated after intracameral implant dosing of travoprost. The other thing that's cool to see here, so that again is showing that it's sustaining the concentration of the medication over the course of 24 months. But the average amount of travoprost remaining following explant. So essentially at different time points, they went in with some of these patients. They took out the iDose and they measured how much medication was still within the canister. And you can see, obviously it's going to go down over time, but 16% of patients, even at 24 months, still had medication in the canister. So this suggests that this can keep concentrations of this medication up and efficacy of this medication for a number of years, 2 to 3 years there. 69% of iDose TR subjects were well controlled on the same or fewer topical medications in the phase 2b trial at 36 months. So again, another option that we now have available to us to help improve compliance and targeted efficacy. And this is a study that we just published this year out of our clinic. Here, that iDose in conjunction with cataract surgery demonstrates about a 10.6 millimeter of mercury reduction from baseline at month 3. So, if you've got a patient with a cataract, they've got glaucoma, and maybe they're doing well on drops, but you just want to help improve their quality of life, send them to, somebody that does cataract surgery combined with, iDose there, and you can drop them into the middle teens, improve their vision, quality of vision by removing that cataract, and then keep that pressure under control and get rid of that eye drop on top of it potentially. And that shows, consistent unmedication reduction across all clinically relevant criteria. So, almost a half of the patients are getting pressures of less than or equal to 14 millimeters of mercury, but the vast majority of them, 16, 18, 20, we're definitely dropping those pressures from the ocular hypertensive stage down into much safer ranges. So it really is showing benefit in combination with cataract surgery as opposed to just cataract surgery alone. The phase 3 and phase 2b data confirm the favorability safety profile of the travoprost implant as well. So phase 3, 93% of slow release subjects well controlled on the same or fewer IOP lowering medications. 92% at 12 months in the phase 2b, 72% at 24 months, and 69% at three years essentially. So another thing to combine, 81% of patients, the slow-release travoprost in the phase 3 trial were completely free of IOP lowering topical medications at 12 months. So just more data to prove the efficacy of this. And then this again is just showing more data over time in terms of, no patient in the exchange study exhibited adverse events of endothelial cell loss, greater than 30% over that extended evaluation. So you can see the endothelial cell counts there over that time with the different studies over the course of 3 years and the redosing baseline and second dose. So very safe thing to have implanted in the anterior chamber. But just like bimatoprost, you've got a travoprost version of that as well. That's what OTX is looking at. It's a travoprost implant, a very similar concept to bimatoprost, intracameral injection. So you've got travoprost loaded into microparticles in the hydrogel. It's preservative-free. It's administered via that single injection with a proprietary injector. This one's 27 gauge. Implant resides in the iridocorneal angle, hydrates in about 2 minutes. It's fully biodegradable. And the duration has been shown about 4 to 6 months with this. The IOP lowering effect approximately 25 to 30% through 4 months. So for me, again, this is a way to potentially get patients off of drops before as a prep for surgery. Just another video of how easy it is for a provider to administer. Quick and easy, just like that. The data on this, in green, just the study eye versus the baseline eye on topical travoprost. So usually much better IOP lowering effect from that. Again, because it's more concentrated, more targeted. This is just how they visualized it over time. They impregnated it with fluorescein so that it was more easily visible and pretty much gone by month 7 there. So a little bit faster than something like a Durista, but the same concept overall. Envisia Therapeutics has their own version of something like this, a biodegradable polymer system that delivers proprietary formulation of travoprost. You can see the size of it. They have a couple different sizes. They have a large size and a small size. This is the ENV515 that I was talking about. So again, also injected into the anterior chamber in the clinic setting. Targeted duration about 6 to 12 months there. We're getting about a 7 millimeter reduction, 26% reduction in IOP from something like that. The Evolute punctal plug delivery system, novel concept, interesting concept. Essentially, you put this core into the cannulicular system, and then it's got a plug of medication that releases over time. They had a couple different versions of this, the Evolute and the T-Volute. I'll show you the data on that. But easy to place and remove in terms of placing into the cannular plug system there. It's cosmetically invisible, just like a punctal plug. It's tolerable for the patients. It provides that consistent, sustained delivery, and you can utilize it in multiple disease states. In terms of that plug retention rate here, that's our biggest concern with plugs is, are they going to fall out over time? In this case, it's shown through the 4 weeks, 8 weeks, and 12 weeks, which was the end of the study, that in all the different ones that they did, that plug was pretty well retained in most of these patients. Here's the data in terms of the change in IOP. The animal models confirms greater efficacy of the T-Evolute model there, but the L-Evolute model also showed, pretty good reduction in IOP over time there. Todd, this is a contact lens. Probably not going to work out at the end of the day, but this is worn by a patient under their eyelid and is easily replaced and prescribed at intervals of months to weeks, depending on what the condition, the stage of the condition. The animal studies showed pretty promising reduction in IOPs here, 37% in reduction from baseline when loaded with timolol or latanoprost. Here's the problem. The human retention rate was found to be about 70% with no safety concerns after 4 weeks of wear. So, can fall out, can be uncomfortable, but, when it's in position, it works pretty well. Additional human studies on the timolol prostaglandin analogs and combination timolol and prostaglandin analogs are ongoing right now. It's smaller in size. It's at the end of the day, it's just going to be a concern for, infection and comfort. But when in place and staying in place, it seems to be working pretty well. So if they can refine that technique, something that we'll have as options to us as optometrists to easily reduce drug dependence or drop dependence as well, and improve compliance here overall. This is something that I'm also very excited about. This is called the Spyglass. So think of this as your PCIOL with a couple um, pads on the side of it that are going to release medication for the patient over time. So they just load this guy up on their inserter. They do their phaco emulsification, remove the natural lens, implant it, and now this is just going to release medication over time here. So in terms of the data that we have on this, IOP reduction about 44.6% at month 12 compared to preoperative washed out baseline levels. It's a drug delivery system, so it isn't necessarily just travoprost that they can put on this. They can put whatever they want on it, but all patients sustain more than a 20% IOP reduction from baseline and IOPs of less than 18 millimeters of mercury through 12 months. So 100% of patients remain off a topical IOP lowering drops. That's pretty substantial, and no adverse events related to the product so far in terms of what they're studying. This is still being studied right now and something that we're participating in our clinic with. So I'm excited to see the data come out on this over time. But another way for non-glaucoma fellowship trained surgeons to get medications and treat glaucoma to patients, especially if they're doing routine cataract and refractive surgery, this is a way that they can load an implant with medication and then just do a quick little surgery that they're comfortable doing, and kill two birds with one stone. So, questions I get asked all the time then, for me in my setting, when do I use drug delivery? Well, for me, it's really anyone with compliance issues. Again, I'm not saying that drops aren't appropriate, that we don't use drops, or that I myself don't use drops. But if you give me a reason to believe you're not utilizing those drops consistently, that's when I'm starting to look at things like drug delivery or SLT. So after SLT, it could be a complementary mechanism with a PGA. I can often consider it as a first-line therapy, something like a sustained release from a Durista for a period of time. During a MIGS procedure, we can add that like an iDose in conjunction with a canaloplasty perhaps. Really after any mixed device, if they do a mixed procedure, that doesn't stop us from going in and doing something like drug delivery afterwards, or, even after trabs or tubes, if the patient still isn't controlled as well as we want, and we're thinking about, restarting rescue therapy and putting them on another, a PGA, for instance, this would be a way to try to keep them off of those drops and still treat the pressure effectively. Which device and at what stage really just depends on the technique, the office, the ASC, the reversibility of it. What do we need to do? This is a video that I kind of alluded to earlier today, where this patient is having a Zen procedure, but you can see how calm the conj is there to the right, as opposed to kind of red and injected from something like a PGA. It's the hyperemia that you might see. That conj is a lot more calm, and that makes Dr. Singh a lot more amenable to doing a procedure like this. And you'll see here why he was.
In the intrascleral wall, and about a millimeter in the anterior chamber. Here's a gonioscopic view, just kind of confirming where the Zen is located. You can see about a millimeter or so in the anterior chamber, coming at the level of out at the level of the TM, maybe a little bit anterior to the TM, which is where you want to be, and parallel to the iris, away from the nice little Durista hanging out down below. There you go. There's my Durista hanging out. Again, we placed this about a month and a half prior to surgery.
So in the interest of time, I'm going to skip here a little bit fast, but moral of the story is we put that Durista in there, prior to surgery to calm the conj down so that he would have a higher chance of success post-operatively. And then moving into the breakdown of conventional outflow MIGS procedures now. This is already outdated with how much advancement we've made in technology. Here to the left, I have iStent Inject listed. It's actually the iStent Infinite now. Inject was 2 stents. Infinite is now 3 stents. Hydrus is still widely available. Streamline Streamline is a goniotomy canaloplasty device kind of all incorporated into one. Omni, iTrack, iPrime, there's various forms of canaloplasty and viscoelastic ways that make it easier for our surgeons to perform those procedures, break herniations in Schlemm's canal, for instance, and improve the outflow to the episcleral venous system, and newer and easier ways for our surgeons to do goniotomies, such as the KDB or the Omni procedure combined. It's got the GAT combined with the Omni device in itself. I'm going to blow through this a little bit in the interest of time, but these are videos of, iTrack, for instance. It's got that little probe with the flashing light on the front of it so that the surgeon can see where he's at. But when he retracts here, you're going to see blanching of the vessels that show a successful connection to the outflow
But
system.
now that the catheter's already in the canal, I'm already on the other side. I'm going to show you, though, with the catheter in there, what it looks like in terms of intraoperative OCT. So on the bottom, you see this ovoid black area down below there. That's the catheter in the canal. And there's a that's kind of black line next to it. That is actually the collector channel. That's the actual opening of the collector channels. And you can see how the catheter, and I say the TM is kind of bulging towards the anterior chamber there. That's actually showing us that we're kind of pushing TM and stretching open TM kind of into the anterior chamber as well. So this is kind of real-time evidence that we have kind of accessing and addressing really all points of resistance, the trabecular meshwork, canal, and the distal collector channels as well. So it's kind of nice to see real-time evidence of what we're doing. And now I'm retracting back. You see the blinking light. As I retract back, I'm having my technician click about 3 clicks per clock hour. So you can see the blanching that's happening in the limbus or near the limbus as I'm retracting this catheter out of the eye. So you see real-time evidence also of blanching without doing INA, just the visco delivery itself, showing beautiful blanching of the perilimbal vessels, which is, again, nice real-time evidence. Thank you, everybody.
So just, newer techniques, newer technology that makes it easier for our surgeons to, confirm that they are connecting to the outflow system effectively and that our procedures are working well. This is the Streamline. So, just goes in really quick with it, presses on a little lever that's going to insert there. He's going to insert some viscoelastic. So he punctured a little hole into the TM, and watch the blood, vessel there. You'll see a little arrow show up here and you can see it just kind of blanch. So that shows him that he made successful connection to the outflow system by, pushing that viscoelastic in there. Whereas we might not have been able to visualize that as easily in the past. So just improve surgical standing. This is the iStent Infinite. We'll skip past that. This is the excimer laser that I was talking about that creates those microchannels comparable to, in my opinion, the VLAs that I was showing earlier. But this is an invasive procedure, so we have to go in with a minimally invasive incision, about 2 millimeters, and then across to the nasal angle. So we're restricted to the nasal angle. And we fire a little laser and we remove the TM, create access to Schlemm's canal and improve outflow that way. And essentially we can, do that as many times as we want. And this is what it looks like in terms of, live or surgical. So still minimally invasive. They can do, up to 10 of these in the nasal angle. And the data on this is where I was saying it was pretty promising. If the VLA shows anything similar to this in terms of concept, these patients are stable in the middle teens for up to 8 years. So again, imagine doing SLT a number of times, keeping the patient off of drops potentially for 3 to 5 years, and then docking them with the VLAs. And if it gets similar results to something like this, or even moving to this in ELT, we can keep the patient off of drops for a number of years here. CPC, cyclophotocoagulation, we're probably all familiar with endocyclophotocoagulation, which where you have to go inside invasively. Cyclophotocoagulation is a laser procedure primarily used to treat glaucoma by lowering the IOP, targeting the ciliary body, just like, endocyclophotocoagulation. And then that's going to reduce fluid production by destroying the ciliary body processes there. But how we do that, this laser, is delivered through the sclera. it's not done, invasively. So it's a lot easier to do. It's a lot easier on the patient, a lot more comfortable, and it still lowers IOP by about 20 to 30% on average, helping control that glaucoma progression there. And in this case, because it's less inflammation, it's easier to manage postoperatively. So we have different types of CPC. We've got transscleral diode CPC. This is the most common. This is continuous wave. It's non-invasive, but the laser probe is applied to the sclera without incisions and then just go all the way around. And again, continuous wave with that. So there's no stops, there's no burst. Micropulse CPC is the newer version of this, something that we're utilizing more in clinic. I don't see the endo anymore. I don't really even see the transscleral diode CPC. We see the micropulse, which utilizes these pulses of laser energy to minimize inflammation and still deliver those short bursts enough to remove those ciliary body processes. Thus, it reduces side effects, less inflammation. And then again, we had talked about the endoscopic CBC. That is minimally invasive. That goes inside the eye, direct visualization. It's more precise, but more painful, more inflammation post-operatively. We're typically utilizing CPC in the refractive glaucoma space. So when all the other treatments have failed, this is a way that we could bring something out, again, being less traumatic to the patient, even when the patient still has poor visual potential. Again, most patients experience a significant reduction in IOP with this. The effect may diminish over time, and repeat treatments can be necessary due to the ciliary body process regeneration. You can also reduce the need for glaucoma medications, but again, not always eliminate them. Let's talk about Alloflow. This is kind of the newer version of superciliary shunting. The idea here is that we're creating these microtrepanations, essentially a scaffold between the ciliary body and the scleral wall there. So we're stenting and reshaping there. This is well established. The concept, at least, it's been utilized for decades in glaucoma surgery, and the tissue that's utilized in this is readily available from eye banks. The stent is designed from that organic biotissue. It's shaped for that cyclodialysis reinforcement. It conforms. It's not super rigid there. So it's soft. It can be, placed easily for the surgeon into the wall there, and there's really no hardware that sticks around, so less chance for the body fibrosing and rejecting. I'm going to blow through a lot of this here in terms of technique, but it'll be available for you in the slides. But it's pretty easy for the surgeon to place. Here's Dr. Singh doing that. There's a lot of heme in that area right now as he's making his cleft, but he just slides the stents in place pretty easily. A little out of focus here in terms of view, but it just goes in there, nicely. And then he'll put another one, in the interest of time next to it. And this is kind of what it would look like post-operatively there. So, used again for patients in primary opening glaucoma who have failed other surgical interventions or are intolerant to medications. It's often combined with cataract surgery or other MIGS to optimize the IOP reduction. It's suitable for patients with open anterior chamber angles without significant ocular comorbidities. This is just what the material looks like, some of the safety and efficacy. It's pretty safe thing there. So, Greg, we'll move to poll question number 2 here.
Okay, let me see if I can find her because they're not in the same order. That was 4. All right. Nope, that's not it. Nope, that's not it. Must be this one. It figures. Last one. All right, go ahead and read the poll.
All right, so what is the primary advantage of micropulse transscleral cyclophotocoagulation compared to traditional continuous wave cyclophotocoagulation CPC? So choice A, it utilizes continuous laser energy that maximizes tissue destruction. B, it employs micropulses to allow tissue cooling between bursts, minimizing collateral damage. C, it eliminates the need for prospective or postoperative anti-inflammatory medications. And D, it exclusively targets Schlemm's canal instead of the ciliary body.
So I just want to remind everyone while this is rolling in with this question is that, Jeff's doing a great job here of showing all the MIGS procedures, all the treatments to the trabecular meshwork, to Schlemm's canal. And I always like to remind everyone is that, glaucoma is a disease of outflow. And the tissue in glaucoma is different. I don't have glaucoma. Patients of mine do. So my trabecular meshwork tissue is different than a glaucomatous trabecular meshwork. It becomes oxidatively stressed. It becomes sticky. It sticks to Schlem's canal. It clogs the collector. So once it gets through the trabecular meshwork into Schlem's canal, it gets to a collector channel. And they've shown that when the pressure goes up, that sticky trabecular meshwork can herniate up into a collector channel. And even when the pressure comes down, it still remains clogged. So the key here, when Jeff's going through all these different procedures, is remember the trabecular meshwork of a glaucoma patient is not healthy. It's sticky. It's oxidized, right? That's why you hear me sometimes saying, that's where, antioxidants will work. It's kind of the allopathic side with all these, or that's the naturopathic side that complements these allopathic treatments. Remember, it is diseased, it's sticky. That's why whenever you stick those probes in, you want to see maybe the Schlem's canal expand because it might be collapsed up against the back wall and the fluid can't get through into the collector channel. So just remember it's a diseased process, diseased tissue. It's not the same as normal tissue. All right. So looks like we have, and I'll display the answer here after going through all that. Joe, are there any questions?
There are none. We're all caught up.
Okay, perfect. So with that said, I'm displaying the answer. Your answer is B here at 80%. 11% went for C, and then 5% went for A and D. So A and D
Yeah.
at 5%, and then 82% now at B, and 10% at C.
So that was kind of me being a little tricky there. We're not eliminating the need for post-operative, anti-inflammatory medications. We're just reducing the amount of inflammation that's there. So these patients are still going to be on anti-inflammatories post-operatively, but we're going to see significantly less inflammation, and they're going to be, a lot more comfortable and they're going to heal a lot more quickly. So that's one of the benefits of this. I got to move through these a little bit more quickly too, just to get to some of the diagnostic stuff here. But Aqualumin, think of this as Zen without Zen, where essentially this is implant free. It's going to create a scleral tunnel that then creates a nice filtering bleb through that area here. So this procedure is performed with a transconjunctival approach that creates a shallow scleral tunnel communicating with the anterior chamber and the subconjunctival space. It's designed essentially to create an efficient filtering bleb through that small self-sealing conjunctival incision, minimizing tissue disruption and reducing the risk for anterior chamber shallowing. This quick little video of what it looks like, the device itself, the little tip that creates the scleral tunnel. And a quick little video, mitomycin C to help prevent scarring. Viscoelastic instilled to keep the eye formed. And then they create a nice little tunnel. So I like to call it Zen without Zen. This is a video of it. We'll skip over that. But, in terms of adequate bleb morphology, that's always a challenge, trying to, keep a low-lying diffuse bleb with minimal vascularization. This has shown that we have an open scleral tunnel there 8 months postoperatively with still a nice low-lying diffuse bleb. So a nice option for our surgeons out there. Poll question 3, just to make sure everybody's awake here.
Hey, it is open.
All right, so number 3, the Alloflow device functions primarily by A, ablating the ciliary body to decrease aqueous humor production, B, delivering a sustained prostaglandin analog into the anterior chamber, C, reinforcing the cyclodialysis cleft with a biocompatible scleral allograft to maintain uveoscleral outflow, and D, incorporating a microstent to bypass Schlem's canal.
The answers are rolling in. I'm going to assume, Joe, that there's, in that quick short burst, that there was no questions or comments.
That is correct.
All right, so I can see the answers rolling in. I haven't displayed it yet, so you might have to go for an explanation on this one. There isn't a clear winner.
So it's C, reinforcing the
Up,
cyclodialysis cleft.
up. All right. I didn't display it yet. All right.
Okay,
Okay.
sorry.
That's okay. You can go over the answer here. I'm displaying it. It was 46 and 46 until the answer was displayed. But so we have 3% being A, we have 12% being B, and there was a split between C and D if you want to go over the results or the answer.
Yeah, so again, this is creating a cleft between the ciliary body or the ciliary body and the scleral wall and helping reinforce that to create better outflow there with biocompatible scleral allograft tissue as opposed to a microstent in itself. All right, let's move into diagnostic innovation. I'm going to skip over this just for the safety of time, but essentially, this is a wearable device that we'll have for our patients out there, especially promising in some of the normal tension patients. That is essentially a negative pressure device that can be titrated. So, think of the effects of gravity when we're laying down, on our backs, how that can impact the pressure, especially when the patients are sleeping. We can have them put on a device like this, titrate it so that it kind of counteracts those effects. Site score is something that I utilize now widely in clinic. I'm very excited about this. This is a polygenic risk score assessment for primary open-angle glaucoma. So it's essentially a genetic risk assessment for that. Site score is a saliva test that looks at millions of genetic variants in a patient's genome to create personalized polygenic risk score for primary open-angle glaucoma. So when we want to talk about personalized treatments for our patients and assessing and picking up and diagnosing a risk or the patient's assessment for risk earlier, this is one of the ways we can do that. The score provides a patient's risk of developing glaucoma and a range of risk information related to disease progression. Site score seeks to identify at-risk patients sooner. The site score is based on world-leading research. It's evidence-based and it has been validated in large clinically relevant cohorts. If you're like me, you've been out of school for a long time now at this point, you've probably forgotten what a polygenic risk score is. We as humans, we share the same genetic code apart from certain differences. These are called genetic variants, which make us unique, and some of those genetic variants are associated with increased disease risk. So a polygenic risk score is going to predict disease risk by counting thousands or millions of genetic risk variants. And then they can tell you essentially here in that diagram who's at higher risk versus who's at lower risk for developing that. And then based on that test, it's going to use those 7 million genetic variants that it has. Which is constructed from data over 1 million individuals and published in the Nature Genetics. It's validated in all ancestry groups and large clinical cohorts, and it gives us risk of developing glaucoma progression, and severe disease over time. This is just some of those data on that. But here's really four main points that comes off on that report. It'll tell us, if a patient's unaffected without family history of glaucoma, what their lifetime risk and age of onset is. If a patient is unaffected with a family history of glaucoma, it can do the same thing, give us an assessment of lifetime risk and age of onset. If a patient has glaucoma or ocular hypertension, it's going to compare that to other glaucoma suspects and tell us, what the likelihood for treatment initiation for something like an incisional surgery is going to be within 3 years. And then if your patient has glaucoma, you might be asking yourself, why would I run a genetic test on somebody for the risk of glaucoma if I already know that they have glaucoma? Well, like I was saying earlier, it's going to tell us not only the potential need for when incisional surgery can come around the corner, but the need for treatment escalation. And here's the other, option reason you can offer this to your patient, is it can give you a risk for a family member, a first generation member, likelihood of them having glaucoma as well. So, if you've got a patient that has glaucoma, it can help you generate business essentially by saying, hey, you should probably bring, your brother, your sister in here and let's run this test on them too and see what that says. This is what the report looks like. It'll give you, the patient's name and the percentile essentially that they will show up in, certain, what their likelihood of being a glaucoma suspect is and developing glaucoma. If they're a high risk, it'll tell you, this patient's in the 95 percentile. Risk that a first degree family member has glaucoma, in this case, 49.6%. The likelihood of them developing glaucoma, 91%, the risk of treatment initiation within 3 years, 15.4%. So on some of those people that you might be kind of on the borderline, ocular hypertensive, for instance, where you might be losing sleep at night going, do I treat them now or do I treat them later? This is a way that you can run a test, give you a little bit more data to further inform your diagnosis and tell you, at least help you sleep at night about whether or not you should treat now versus later. And in my opinion, the answer is always now. And then what it looks like in somebody who's got a low polygenic risk score. So, it'll tell you this patient's likelihood of treatment initiation within 3 years, less than 5%. That's where you can go, okay, this, like I thought, we want to monitor you. This helps me say, yeah, we should just monitor you at this time. And then this is a more, in-depth example again of a patient that's higher risk here. In this case, 88% risk score for glaucoma, 23% escalation within 3 years, 34.3%, requiring incisional surgery there, and then 57.6% that a first-degree family member has glaucoma. Poll question number 4. Firing them off at the end here.
Okay, we are open.
So, what feature distinguishes Aqualumin from other MIGS procedures? A, it relies on a biodegradable implant to maintain filtration. It creates a filtration channel via an implant-free external micro excision technique. C, it combines trabeculotomy with cyclophotocoagulation. And D, it requires intraoperative gonioscopy for targeting the trabecular meshwork. Looks like I copied and pasted the answer there. So everybody should be able to get 100% on this one.
Yeah, the trend is coming in.
We're good on the chat. Everything's fine there.
So we'll kind of display this. We have 76% going, or 74% going with B, and the other were about 10% were A, B, and D.
All right, let's move on. So OCT angiography, this is something that I've been utilizing widely in clinic as well. This is, think of it as like fluorescein angiography, but doesn't require, dye injection. It's going to provide us with both structural and vascular information. The OCTA uses high-speed OCT scans to detect the motion of red blood cells within the blood vessels, generating that high-resolution three-dimensional images of the retina and choroidal vasculature. Key metrics that this kind of gives us is vessel density in the peripapillary and macular regions. And this is really what we look at as a primary quantitative measure reflecting the health of the microvasculature relevant to glaucoma. But there's different imaging protocols depending on the instrument that you have. There's different versions of the OCTA. So, they can use spectral domain and SWEP source technologies, but it is going to offer a little bit deeper penetration and faster image acquisition by utilizing both essentially. And this is terminology here listed for you for reference. You can look that up in the slides. But the moral story at the end of the day here is this can help us, when, say, the OCT is failing, or we've hit the window, effect, or you've hit more of the end stage, or even in the earlier stages. If you want to detect earlier, you can get a baseline here of what a healthy nerve looks like. You can see that right here with good vasculature around the nerve itself. And you can see what it looks like down here when that vessel density drops off over time due to, tissue loss and glaucomatous progression. So this is a way that you can have a measurement without having to worry about, are my visual fields accurate? Is my, RNFL scan, is the quality good there? If you get a good quality scan with this and you see some progression with that vessel density, but, your RNFL scan is looking pretty good and your visual field is not showing any defects, this is a way that you could potentially detect earlier Or like I said, if you're in more of the end stage of disease and your tests are becoming more unreliable, you've got a significant amount of visual field loss, and the nerve is pretty cupped out at this point. You can monitor vessel density as well to give you some more quantitative, objective measurements there to really see how the patient is doing. So I kind of talked everything on this slide. I kind of just touched on already. So early detection, there, better differentiation. And it's particularly valuable in those challenging cases such as high myopia or advanced glaucoma, where those traditional structural measurements may be less reliable due to the artifacts or floor effect. It has its limitations too. You can have artifact just like any other image. It can be affected by motion, media opacities. And as I was saying, there are different OCTA machines and different post-processing algorithms that can yield varying results. So consistency in equipment and protocols is important there. You've got integration with AI that's coming up. I have a whole thing about AI at the end of this I'm not going to get too much into here, unfortunately, due to time. But essentially, we're going to be able to monitor trends more accurately, data sets more accurately, and AI in itself is going to be able to help us pick up on things. And the last thing I'll talk about tonight, and then we'll finish up, is the Ocumet Beacon. I'm very excited about this. This is essentially a non-invasive, rapid, think of it as like a fundus photography that detects, move to this slide, FPF, or flavoprotein fluorescence, which is a metabolic process by retinal cells that is emitted from these flavoproteins when they're excited by blue light. And those elevated FPF levels indicate increased mitochondrial oxidative stress, which we know is well established as a key early marker of glaucomatous damage. So imagine being able to take a picture of the back of the eye when you're suspecting glaucoma and see how these FPFs light up, and that tells you likely have some processes going on that are related to glaucoma. Maybe we should treat you earlier. Or you start a patient on a PGA, you want to see the efficacy of it. You've got a patient showing all this fluorescence from this device. You put them on a PGA and that fluorescence goes down. That allows you to monitor not only disease severity and progression, but it gives you an idea of therapy response. So this is something that's going to be available widely to us over the next coming year. Something that'll be really interesting to see the data that kind of shows over time. Here's some studies on it that show its efficacy. I'll skip through the rab and cone. There's neuroprotective therapies that are out there to help protect the retinal ganglion cells. Number of stem cell therapies, gene therapies, mitochondrial targeted therapies that are on the horizon that are being studied to slow neurodegradation. And as we had mentioned in the beginning, nanotechnology and exosomes that are out there to help those neuroprotective compounds get to their targets a lot more effectively. And then AI and glaucoma is just going to help us monitor disease progression and the prognosis and risk stratification a lot more accurately than we are currently doing now with our technology. So we'll finish up with poll question 5 here.
Okay, it is open.
Okay, so which of the following statements best describes the purpose of optical coherence tomography angiography and glaucoma management? A, it measures corneal thickness and curvature. B, it visualizes microvascular perfusion and optic nerve of the optic nerve and retina. And C, it quantifies aqueous humor production. And D, it images the drainage angle using ultrasound.
We're good in the chat.
Okay. And it looks like the survey is going to be opening up. There it is. Survey, the little red dots up for those who want to start to take the survey. And looks like you pretty much nailed it on this one with the audience. We got 97% going with it visualizes microvascular perfusion of the nerve head and retina.
Excellent. You guys are correct. And that's it. I'll end it there. Thank you all for tolerating me tonight and listening in. This is always an exciting lecture for me, and I'll be happy to stick around and answer any questions that anybody might have in regards to the content.
No, I think we are good as far as the content, but I do want to thank you for doing such a great job here. I thought it was fascinating You brought a lot to our audience. I think everybody's going to really be really appreciative of this. So, Jeff, thanks so much.
Thank you guys for having me.
So as we see if there's any questions that roll in for Jeff here, just as a reminder, right here on the survey, there's a little red dot. Please complete that. We need that for our COPE administration. We need that for our CE broker to show that we're closing the gap. So if those who attended could just do that survey, those polling questions, that would be greatly appreciated by Joe, myself, and Vanessa as part of the webinar team. Joe, has any questions rolled in?
Nope, you're just getting a nice virtual round of applause. Everybody's thanking you, and we're very appreciative. I know we're all appreciative of your work here, Jeff, and your presentation. The time flew by. I thought it was wonderful. Thank you.
Thank you guys. Have a good evening, everyone. Thank you for attending.
Thanks, Jeff. And with that being said, no questions, and I'll echo what Joe said. It was a fantastic lecture for our national webinar series. This was the cutting edge of glaucoma management, innovations, and technology in 2025. I think Jeff didn't let us down with that title. So with that being said, this will conclude the education.